So this next video lecture is on schizophrenia, and it's just a very basic lecture, just down and dirty of what schizophrenia is, what we see, and just a little bit about medications. So let's get started. So what is schizophrenia? Well, schizo means split and phrenia is brain. So that defines out a split brain. And we see that in other readings and stuff. But actually it's scattered pattern of thought. So that's what we're seeing is the scattered pattern of thought. And they present very differently, and there are ways of medications and ways of treating and caring for a patient with schizophrenia. Now, I love this picture. It's an Elsevier picture. It's great. Positive symptoms, hallucinations, delusions, disorganized speech, bizarre behavior. Negative symptoms, blunted affect, poverty of thought, loss of motivation, inability to express pleasure or joy. And we have the actual words for those, all our lovely A words: alogia, avolition, and hedonia. And so please learn those terms. It'll be important to know those terms. Cognitive symptoms is the next: inattention, easily distracted, impaired memory, poor problem solving skills, poor decision-making skills, just impaired judgment in general. And then we can have other things going on: anxiety, depression, substance abuse, and suicide or suicidality. And if that's the case, you know, this is not a good combination with everything going on. All symptoms alter the individual's ability to work, for relationships, self-care ability, social functioning, quality of life. So these people really struggle. So we need to be very in tune and ready to help where it's necessary. This is kind of the same thing, but a few more terms in here. You need to know the signs and symptoms of schizophrenia. Positive symptoms and are hallucinations, delusions, and disordered thinking of loose associations between thoughts and voices. This is where we get that auditory hallucinations. It can be the positive symptoms are, it's a new feature. It's not something good. When we think positive, we normally think good, but this is not a good thing. These are even more on top of, and we can have with the positive symptoms also the disorganized speech or word salad, but we definitely have hallucinations and auditory and visual and delusions. So that's in that positive symptoms. The negative symptoms, we can have apathy, social withdrawal. I'm not going to read them all, but that flat effect, we get that flat. Something's going on and everybody's, and they're just there. That's not good. So this is where we have the avolition, which is that avolition is the decrease in motivation to achieve goals. So when you have no motivation to achieve any goal, and we're talking about regular daily goals, this is an issue and a problem. So we see different types of behavior. We have paranoia, which is extreme suspiciousness, delusions of grandeur, hostile and aggressive behavior. This is auditory hallucinations are common with paranoia, and these are the paranoid patients. So it's something that you want to understand what we're talking about. So if somebody says this patient has paranoia or they're paranoid, you'll know that these are the signs and symptoms, but they could be having auditory hallucinations, hearing things, talking, voices talking to them. Catatonia or catatonic patient is stuporous. Rigidity, they're very rigid. Waxy flexibility is keeps the limb in one position for a long period of time. Echopraxia is imitating the motion of others, and echolalia, which I say that horribly and I apologize for that, is involuntary repetition of words. So it's unpredictable behavior. Catatonia is unpredictable behavior. Their behavior is controlled by delusions and hallucinations. Kind of interesting to know that, because if you have a catatonic patient, we need to know. Disorganization is the flat affects, silliness, word salad, delusions, and hallucinations are common. And these are just definitions of terms that are will be helpful to know. Now, how do we diagnose schizophrenia? Well, it's kind of difficult, but the Diagnostic and Statistical Manual of Mental Disorders, the DSM-5, it is produced by the American Psychiatric Association, has a manual or a book that is out with the criteria that helps you diagnose mental illness. Even though schizophrenia is a single diagnosis, most schizophrenics have dual diagnosis or even more diagnoses or more. But be very cautious, because having dual diagnosis of substance abuse and schizophrenia is a great predictor of violence with these patients. They become violent. So we want to be very cautious. Don't be fearful, but be cautious. And in that caution, remember to keep the environment safe. You don't want them to have sharp objects. You don't want them to have anything that could hurt themselves or you. If we are worried about a violent behavior coming from the schizophrenic patient. And the biggest thing we can do is de-escalate, de-escalate, de-escalate. You don't ever want to prod or probe or continue to aggravate or agitate a patient that's already agitated. De-escalate, calm voices, calming them down, getting whatever is needed to calm them. That's what we want to do. So there are different antipsychotics that we can give. There's first generation and second generation. The first generation are the ones that I want to focus on. They're antipsychotics. There's 3 of them. There's more than 3, but these are the 3 that we're looking at. Chlorpromazine or thorazine, Haloperidol, which is an antipsychotic and an antiemetic, and we give it as an antiemetic post-surgical, post-op, right out of surgery. So those are up there, but the one I really want to look at and focus on is Haldol or Haloperidol. It controls motor movements for Tourette's syndrome, and it also helps with controlling auditory hallucinations and issues with an actual schizophrenic patient. It is used to treat schizophrenia. Side effects, though, can be bad. They can have that dry mouth, urinary retention, constipation, muscle spasms of the neck and the back, shuffling walk, and lip smacking. The next few slides that I'll go over are actual side effects of these antipsychotics. And unfortunately, they're not pleasant, but they're not harmful either. So we just have to understand that. The patient needs to understand that. And then also the family or the caregiver needs to understand the side effects of these medications. Now, one thing I do want to point out is that haloperidol can cause neuroleptic malignant syndrome, and this is something that everybody needs to know. Ding, ding, ding. If we have symptoms of high fever, muscle rigidity, change in mental status, they become paranoid, or we have autonomic dysfunction, which these are the nerves, the autonomic nerves are what regulate the heart rate, the blood pressure, and sweating. This is an emergency situation. They need emergency care immediately. If you're in a facility, you need to stop what you're doing and go call a physician immediately. If you are outside of a clinical setting, you need to call 911. What can happen is these patients can actually arrest if we're not careful. This is a life-threatening situation. So neuroleptic malignant syndrome, or NMS, is what can be caused by taking these antipsychotics first generation. So I'm not going to read these slides, each one of them to you, but these are characteristics of acute dystonia. This is facial grimacing. We have involuntary upward eye movement. They can have muscle spasms of tongue, face, neck, and back. The trunk to arch forward, and I guess I did read them, laryngeal spasms. So this just breaks it down a little bit. These are extrapyramidal side effects. So dystonia or dystonic reaction is that acute muscle contraction, especially of the tongue, face, neck, and back. And then we can have an oculogyric crisis, and this is a fixed upward gaze or a muscle spasm of the eye. So this is kind of an interesting thing to know also, but understanding when somebody says they have dystonia or dystonic reaction, we need to understand those side effects of that or what we're visually assessing. And then also too, with the fixed upward gaze or muscle spasm of the eye, it's oculogyric crisis. Good to know. So this is a picture, and this breaks down the characteristics of Pseudoparkinsonism. The stoop posture, shuffling gait, rigidity, bradykinesia, tremors at rest, and pill rolling motion of the hand. And you'll see that this is that pill rolling motion of the hand. We can see that a lot. The shuffling gait. These are things that are a side effect of the actual medications. So these just break it down again, little pseudo-Parkinsonism or drug-induced includes poor balance, flat effect, slowed movements, tremors, and drooling. And we see this, so we need to be aware of it. We also can have manifest as motor restlessness, the tapping of the foot, rocking or pacing, or apprehension and irritability. Akathisia, I can't even say it, I'm not even going to try and butcher it. But it's right here for you to know. It's another A word. So these are characteristics of akathisia. I couldn't get it out earlier. Akathisia is restless. We see it's that tapping of the foot, trouble standing still, paces the floor. We're in back and forth rocking. We can see with this feet in constant motion, that constant movement. That is something that we want to understand that we might see with these patients. The next slide is a great picture because it really does kind of portray it, is characteristics of tardive dyskinesia. Protrusion and rolling of the tongue, they get this tongue movement thing going, sucking and smacking movements of the lips, you'll hear them, chewing motion, they roll that. Facial dyskinesia, we can see what happens in voluntary movements of the body and the extremities. So these are things, and it actually breaks them down on the next two slides for you to understand. Things I want you to know about tardive dyskinesia is it's irreversible after they develop. So if they get this drooling or this movement, it's irreversible after they've developed. Symptoms can include the tongue protrusion. She was doing it in the film, lip smacking, sucking, chewing, blinking, lateral jaw movements, grimacing, shoulder shrugging, pelvic thrusting, wrist and ankle flexion, rotation of the foot, tapping movements. It's all in this, and this is what we can see. It's not good. It's something that we don't want to happen. So we need to stop whatever medications. Never stop abruptly any mental health or mental illness medications, but definitely we need to call the doctor immediately, and that's something we want to teach our family and our patients so that the doctor can address the situation and change either medication or dosage or whatever needs to happen. This continues to break down tardive dyskinesia. Its movements are often described as writhing or worm-like. Monitor for signs of this, particularly in patients that have been taking a conventional antipsychotic medication for longer than 6 to 12 months. So sometimes it takes a while for these to develop. It's not something that just happens. So definitely if they're on a long-term medication, an antipsychotic conventional one, that we look 6 to 12 months for these signs and symptoms, start looking for them, and let patients' families and caregivers know, patient know, and we should know. So a couple other things with nursing is if a patient is on an antipsychotic, no alcohol should be consumed. What happens, they can have central nervous system depression, and that could cause them to stop breathing, and all of that. It can actually kill them. So no alcohol. Develop trust with your patient. It's really important. There's a lot of paranoia with this, and the more trust that we can develop, the better that hopefully the patient will respond to treatment, and that we can make headwaves with them to hopefully get them functioning better. Teach the patient and family how to identify and manage the symptoms, what we see that's normal. When we have these symptoms, which are not our quote-unquote normal social, what we see out there with anybody that doesn't have mental illness, it can become disturbing for people if they don't understand or they don't know what they're going to see. So it's so important that we do help identify and manage the symptoms, and teach that to the patient. Always use therapeutic communication with these patients. Don't let them get you riled up by if they become aggressive with their, yelling things at you, being aggressive in speech or in action. Always stay calm. Remember safety first for you and the patient, and use therapeutic communication. Go back and review your therapeutic communication if you're not good with it. There's no known cause for schizophrenia, and I think that's something that needs to be talked about. Lots of times if there's families that have a schizophrenic patient or family member, their concern is that generations or other people will become schizophrenic based on something genetic. There's some genetic pull to it, but there's no actual known cause. So there's some factors that we can see, but never purely it's genetic. I do know, and I can share the story with you, I do have a friend that has a son that had a head injury at the age of 16, playing football, got knocked out, and afterwards started developing signs and symptoms of schizophrenia, and now is a schizophrenic. Kind of interesting. So I think there's some things that could probably trigger this, but this is all being looked into. It's still really kind of unknown, and a lot of the mental health issues are unknown. We just have to understand that, but we need to help families understand that also. If an elderly patient or any patient do not elder speak, that's where it's, oh honey, it's going to be a honey baby sugar pie, none of that. We need to talk to them as if they're adults, human adults, developed, and even if they're acting a specific way, still don't elder speak, quote unquote, to the patient. None of that. We need to call them by their name. We need to talk to them as adults. This can also trigger patients to become aggressive or actually have a breakdown. So we don't want to do that.